I'm Jessica White. I have the privilege today of introducing today's speaker as I'm the residency program director. Today, our speaker is Dr. Sam Hagman. He's one of our own third-year residents, and so we're super excited to hear him today. Dr. Hagman calls Nairobi, Kenya, as well as Minneapolis, Minnesota home. However, his career path has taken him on a kind of a circuitous path throughout the United States. So he did his undergraduate education at the University of Florida in Gainesville before pursuing medical school at Alabama College of Osteopathic Medicine. After that, he was recruited here to USD Sanford to our great benefit, I believe. However, he initially joined our surgical program before realizing that he was actually a pediatrician at heart with surgical mindsets towards procedures and other opportunities. And so we drew him away from the surgical program to join our pediatric residency program. Dr. Hagman has been very successful during his career in residency. We like to call him the person who is most likely to say yes to a project, an opportunity, or to helping a colleague out. In fact, I was just giving him a hard time right before this that he was going to need to start mentoring in addition to people who are like-minded. However, his scholarly activity during residency has also included national presentations. I was excited to witness his poster presentation at PAS, and today he's going to be talking about a topic that is specifically important to me as a neonatologist, hepatitis C in the pediatric population. This is exciting to hear about, also exciting because Dr. Hagman is currently planning to pursue a career in neonatology, and we are excited to see where he goes. And so with that, I will turn the microphone and your attention over to Dr. Hagman.
Thank you. Thank you guys very much for those who are here and online. And Dr. White, thank you. That was a very kind introduction, so I appreciate that. So as Dr. White briefly mentioned, be doing a talk here on hepatitis C with a focus in the pediatric population, as well as a brief portion that also talking about some QI/research project that we've been doing with follow-up patterns from both our newborn nursery as well as our NICU, and then also talking about what the recommendations for that looks like. I did want to give a special, as I guess is my generation to call a shout out or a recognition to Dr. Messier, who been doing this project with and also helped me with this grand round. So thank you to him. All right, so I'm a kind of a big picture guy where I like to kind of know what the general important points are and kind of what's the general is, and then kind of fill in the details thereafter. So if you're like that, I hope that this is a bit helpful, but I have a bit of an overview or kind of Spark Notes versions of the important points, and then kind of go into a bit more of the details. So from an incidence standpoint, hepatitis C has doubled in 2020 compared to 2013. The reason for that is IV drug abuse is by far the #1 risk factor as well as contributor to contraction of hepatitis C. Perinatal transmission is a much lower percentage of those new cases, however, is still certainly a mode of transmission. Blood products is oftentimes associated with hepatitis C. However, since the early 1900s, this is very, very rare. We'll go into a little bit more detail why that is, but rates from of transmission of hepatitis C from blood products is very, very rare now. Most infections are actually going to be asymptomatic and with a feared sequela of liver damage. Okay, we'll kind of go into some more details of those, but generally you can have non-specific signs and symptoms at best if completely asymptomatic with initial disease. There is 2 ways to test: serology, which you associate with antibody testing, and then also nucleic acid amplification test, or PCR, which is RNA testing. And we'll go into more details on how those are done, but there's a general principle for 2 different types of testing, which are indicated in several different situations. All pregnant women should be screened for hepatitis C, which is a relatively newer recommendation. This used to be a risk-based recommendation of testing. Now it is recommended with each individual pregnancy that each woman be screened for this. The recommendation for neonates and therefore infants later in life would be if there is exposure in mom for risk of perinatal transmission, serology, so antibody testing, is recommended at 18 months of life. There are a lot of caveats to that, which we'll go into, but from a kind of big picture standpoint, if you remember one thing for the purpose of this presentation is testing infants at 18 months of life who had infants that mothers had hepatitis C. All right. And then treatment, unfortunately, there's no treatment for younger than 3 years old, but all individuals 3 or greater should be placed on one of the individualized treatment programs based on their age, weight, and certain other factors, which we'll go into. So I just kind of want to give this basic overview of kind of, if you're just to look at this slide, this is the important points. And if you'd like to leave now, I totally understand that too. But this is kind of the important points here. Thanks for the kind of courtesy laughs there. All right, so just a bit of etiology, kind of bringing you back to med school of kind of what's going on. So it's a single-stranded positive sense RNA virus. There are many different subtypes. In the US, 1A is the most common. The reason why 1A is important is because, and that's my little daughter over there, by the way. The reason why 1A is the most is relevant for this talk is that it does impact treatment. A large majority of the treatments in the US are based on subtype, and 1A being by far the major subtype that we do see here. All right. Oh, speaking of, how did that get in there? Whoops. So this is my little daughter, Zuri. On the right side, that's her first birthday with her birthday donuts. In the middle, I don't know what she's eating, but she's obviously enjoying it, as you can see. So a little bit about some epidemiology, prevalence here. So it's kind of gone up and down, for lack of a better way to put it, but basically it did start to drop in the early 1990s, and it reached its actually low point in 2006. And then in 2020, it's actually doubled since 2013. Okay, large increases due to IV drug abuse. You're probably going to be sick of me saying that, but by far the most common mode of transmission, number one risk factor for contraction is going to be IV drug abuse. Okay, 66% of cases are due to reported injected drug abuse, and both the Red Book as well as Infectious Disease Society of America said this number is a lot higher than 66%. This is going to be similar to where you're going to see the highest incidence of IV drug abuse is going to be in our younger population. So 20 to 29, the 30 to 39 as well are a close second for highest incidence of hepatitis C. 2019 are the most recent numbers we have. About 57,000 cases of acute hepatitis C occurred. And there are about, according to a study from 2013 to 2016, about 2.4 people living with either acute or chronic hepatitis C. This is just a bit of a graph, kind of showing you the significant rise, particularly in these younger patients here. So if we look back at, there we go. If we look back right around 2009, there wasn't a huge discrepancy between your ages here. And then in the 2010 and onward, we see a huge jump in purple being 20 to 29. And then green being 30 to 39, with a moderate increase in the older population, but certainly a much more significant increase in our younger 20 to 40-year-olds. Thought behind that, of course, being that IV drug abuse is going to be more prevalent in that age range. This is a very overwhelming graph to look at, and I apologize about that. But I thought it was nice to kind of see each state based on this. And if you kind of look, South Dakota's middle-ish, we get the unique pleasure of having a big blip here and then kind of a more average number. And I'll zoom this in a second, but kind of some states with higher reported cases: Maine, Florida, Louisiana. And then if you look at a more zoomed in version here, we have South Dakota with the light blue being 2020 and the dark blue being 2019. The light blue being a good amount below the mean of less than 1 per 100,000 cases, whereas in 2019 it had a pretty big jump to about 3.5. Alrighty, so what are the most common ways of transmission? There's many ways of transmission is the summary, but the most common way by far is going to be kind of the broad way of putting percutaneous exposure to infected blood. Okay, most common actual manifestation or actual way that happens is injection drug use. Okay, again, like I said, you're probably sick of me saying that. It said about 60, so I said 66 in the previous, is a different review, but basically about 60% on average, potentially even higher, are secondary to injection drug use. And this is one thing that really surprised me. About 1/3 of people who inject drugs are going to be shown to be infected with hepatitis C, which is a much higher number from my non-experienced mind to from what I would have anticipated. Okay, the other most common mode of transmission is going to be perinatal transmission. So birth to an hepatitis C infected mother. Okay, and we'll go into a good amount more detail on that. On the next slide here, I have some less common modes of transmission. This can be a sexually transmitted infection, particularly in the setting of comorbid HIV infection. There's a couple different areas where co-infection with HIV puts them at particular risk, particularly in the development of secondary liver damage and potentially even liver failure with associated hepatocellular carcinoma. We'll go into that in just a little bit here, though. But anyways, this can be a sexually transmitted infection. Sharing personal items, these are kind of a little bit niche types of things. So if you're sharing a razor or a toothbrush with somebody who is also infected, there is a potential risk of that being a bloodborne percutaneous exposure. Unregulated tattooing, which I guess is hopefully not super common, but I guess probably happens. And then blood products. This is by far much less common here, but it is still a potential risk. Okay, and we'll go into that here in just a little bit. Needle stick injuries is another way. This is also quite rare, but these are just some kind of more rare causes of transmission. Blood products. Is it safe to get my blood products? Is my child going to get hepatitis C? Well, hopefully not. So in 1992, previous to 1992, there was very little testing, or not great testing, I should say, to test transfused products for the presence of hepatitis C. So actually, previous to that, it was the most common cause of hepatitis C. 1992, more advanced screening became available, and these rates of transmission dramatically decreased. Estimated cases less than 1 per 2 million units transfused. So kind of think about that in kind of the amount of times you've placed blood orders or platelets or whatever. Very, very rare that is going to be a mode of transmission. Now, it still can happen, of course, but with better testing, this is greatly decreased. Oh, how did those get in there again? Whoops. There in the middle there is her being kind of sassy with a hood on. And then right there is on Christmas with my beautiful wife there, and her kind of squirming away from me, wanting to go to my wife, which gift kids is kind of the crux of being a dad, that daughter's always trying to go to your wife. Not that I'm bitter about it at all, but happens all the time. All right. So what are clinical manifestations? I kind of briefly said in the overview. Generally, it's going to be asymptomatic, and that is generally the case. Okay. There are some non-specific signs and symptoms. So fever, fatigue, dark urine, clay-colored stool, abdominal pain, jaundice, these things that you see 1 or 2 of these and you go, oh yeah, probably got something viral, or oh, probably not too big of a deal. We'll see you back in a week or something along those lines. But in the setting of an unknown social history or unknown drug abuse history, injection drug use history, really non-specific things you probably wouldn't really cue you in. So a lot of these infections, what I'm kind of getting at with this being asymptomatic, a lot of these infections are going to be incidentally found. Okay, so whether that's going to be a bump in their liver enzymes, whether that's going to be a screening test for pregnancy or something along those lines. A lot of times, patients are not going to actually know that they have hepatitis C. And I apologize, I didn't mention that this is kind of we're referring to the acute infection, okay? And we'll kind of go into acute versus chronic. But for that first 6 months, which is what is termed the acute infection, really going to be non-specific signs and symptoms. Chronic isn't too much different, to be honest, except for kind of the feared sequelae of liver injury. So from a chronic standpoint, about half, give or take, of people who are infected with hepatitis C will develop chronic infection. Unfortunately, in the pediatric population, that is a bit higher. It's about 80% in the pediatric population. Okay, what is a chronic infection? Well, chronic infection is the presence of RNA, okay, as well as antibodies. So that's serology testing. 6 months after initial exposure, that would term you to have a chronic infection. Okay. Oftentimes, similar to your acute infection, it's going to be asymptomatic, maybe some non-specific signs and symptoms, jaundice, fever, clay-colored stools, but really overall pretty non-specific. So the feared complication, and the reason why I guess even this talk is relevant and why we talk about the pediatric population as well as the adult population, is there is a risk of chronic liver disease. Okay, so this is not a true continuum. This is not a true continuum, but it can be seen on a continuum, meaning that one will lead to the other. But cirrhosis being liver damage, hepatocellular carcinoma being actual malignancy neoplasm of the liver, and then eventual liver failure. Why these are so relevant is obviously this impacts treatment, okay, as well as this can impact many medical complications as a result of this. So obviously, this is something that is monitored very closely in the setting of chronic infection. Okay, we'll go into these here a little bit as well as treatment here as we get going. All right, so chronic infection, continuing on. So when you think about acute versus chronic in the adult population, you're normally thinking about 50% developing acute to chronic, pediatric 80%. Okay, so just keeping those kind of numbers in mind. So given that's a pediatric presentation, let's assume 80% of acute will get chronic. Okay, of those chronics, about 15 to sorry, I'm hitting the mouse here. About 15 to 25% will develop cirrhosis within about 10 to 20 years, which is a pretty significant or a pretty surprisingly high number. Okay, of those, that 15 to 25%, 4% annual risk of hepatocellular carcinoma. Okay. There are some risk factors for developing cirrhosis. So for that 5 to 25% being potentially even higher, male, age greater than 50, but the by far number one and what's really harped on in Red Book, Infectious Disease Society of America, a lot of different resources, alcohol consumption. And we'll kind of go into a little bit about anticipatory guidance and discussing, but really the number one recommendation for hepatitis C at acute contraction, particularly at chronic manifestation, is complete cessation of alcohol. So not moderation, not just here and there, but complete cessation. Now, the real world, that's not always going to be the case for a lot of patients, particularly in a particular population with injection drug use that predispose them to that infection. However, that's going to be the number one thing from a non-medicine standpoint to help prevent worsening of infection. Okay. Other potential complication or potential risk factors that will increase your risk of potential liver damage: non-alcoholic fatty liver disease, Hep B, HIV co-infection. And then, of course, if you're receiving immunosuppressive therapy, that's going to put you at a greater risk as well. So the details of this chart are certainly beyond the scope of this talk. But the CTP classification is a classification which discusses the severity of cirrhosis. Why this is relevant is this does impact your treatment, because almost all of our treatments that are going to be readily available that are most commonly used are only going to be for class A. Okay. How they determine this treatment is going to be based on their bili, their albumin, their coags, ascites, and then any presence of encephalopathy. Okay. So if you're in the class B and the class C, so the more severe cirrhosis, they are not going to qualify for the general treatments, and they're going to have to be have an individualized management, which we'll go into in a little bit here. But mostly, you're going to be thinking of Class A as more amenable to treatment. Okay. All right. So there are two types of diagnostic testing, which I briefly discussed before, but I want to go into a little bit more detail here. So when you hear serology, think antibody. Antibody, think serology. Serology, antibody, so on and so forth. So serology testing tests for anti-hepatitis C antibodies, okay? There are many different types, which are not really important for this talk, but when you think of serology, antibody testing, okay? Nucleic acid amplification tests, which detect RNA, PCR being a part of this as well as an example. This is going to be actually looking for the presence of hepatitis C RNA. This can be both qualitative, meaning that is it present or not, and also quantitative. So what is the viral load? And in perinatal transmission, that becomes particularly important. There's a much higher risk of perinatal transmission when the viral load is going to be higher. This can detect current hepatitis C infections. So when we go through our little diagram here in just a second, we'll discuss kind of reflex testing for a positive antibody or positive serology. This is what this is used. But it can also be used to monitor response to antiviral therapy. So start somebody on therapy, 8 to 12 weeks later after they've completed therapy, you say, okay, what is our viral load looking like? Has this been a successful treatment? Have they even gotten worse, or they've been about the same? And that helps determine kind of where you're at from that standpoint, as well as further monitoring. So when you follow up with them from an ID standpoint in 2, 3, 6 months, whatever it may be, where are we at on a viral load standpoint? Okay. From detecting from a serology standpoint, it only takes about 8 to 10 weeks in order to develop an appropriate antibody response in your typical patient who is not immunosuppressed. RNA, however, can be detected about a week afterwards. So that does impact our testing. So how do we test? Well, I'm glad you asked. Thanks for asking. So generally screening purposes, so meaning that is there an infection or not, you're going to be testing with serology. Okay. So this is a great example is going to be in your pregnant mothers. You're not going to generally off the bat, if they have an unknown history and you're just doing a general screening as a part of your prenatal labs, you're going to be testing their serology. So, hey, do they have antibodies to hepatitis C? Okay. Reflex to nucleic acid amplification test. So meaning that, oh, okay, we did get a positive screening test for hepatitis C antibodies. Now I'm going to reflex to test for RNA. Generally, that's going to be both a qualitative as well as quantitative. So wanting to see what their viral load will be like, particularly in a pregnancy standpoint. Okay. So there are exceptions. So when would you start with PCR testing? Okay. And it's kind of a general rule, from a resident standpoint. We use serology testing often, and we also use PCR testing. So this is a general guidelines for hepatitis C, but also can be used for a lot of viral infections where we're doing these tests in the hospital where, hey, let's test for this virus. Well, do we test with antibodies? Do we test with serology? Or do we test for RNA? Well, that these rules remain somewhat the same. So if there's a needle stick injury, okay, well, as we previously discussed, it takes about 8 to 10 weeks to mount an immune response with antibodies. So is going to be waiting after needle stick injury 8 to 10 weeks going to be the best option? Well, probably not. Probably should test for some RNA, right? You can test before seroconversion, and you can really, if indicated, could get somebody on treatment or have a better idea what's going on. Okay. Infants, we'll talk about more on this later, but it is very common where infants will actually be tested at 2 months of age for RNA. And next question might be, well, Sam, I thought you said that you're supposed to test at 18 months. That is the recommendation, but there are many exceptions to that. And oftentimes that is just kind of one part of the picture. Okay. All right. So if somebody is immunocompromised, they're on hemodialysis, basically, if you can't trust their antibody response, you're going to want to test for RNA as well. So somebody who you're saying, well, there's no antibodies. Well, I don't know if I'd really expect there to be a great antibody response in the first place. Probably better to test for their RNA. Okay. And then, as I mentioned, monitoring response to antiviral therapy, saying, hey, what's our viral load? Have we improved on this standpoint? Have we worsened? Are we about the same? It can help us to know for that. Okay. So this is just a bit of a diagram here. If you're like me and like things that just break it down simply for a simple-minded person like me, this is kind of a nice way to do it. So at the top here, and I guess I should use this for those online. So hepatitis C antibody testing. Okay, so antibody we associate with serology, right? So hepatitis C antibody, we go to this side here. Oh, it's not negative or non-reactive. Well, there's no current hepatitis C infection. There's no, as far as we can tell, no previous hepatitis C infection too. Stop. Simple answer. Okay. Hepatitis C antibody serology was positive. Oh, okay. Well, so then we reflex to RNA testing. Okay. If we reflex to RNA testing and that is not detected or negative, then we can say with good confidence that there is no current hepatitis C infection. Okay. But there likely was a previous infection, and there's a quite complicated mode of kind of further management and workup for that, which is beyond the scope of this talk. But generally, if there's going to be negative RNA, there's going to be not going to be a current infection. And if you did have antibodies, probably inappropriately either treated or resolved infection is what that indicates. If you get the positive antibody, so serology testing, and you reflex to RNA and the RNA is detected, that does indicate that there's likely a current hepatitis C infection. And anybody 3 years old or older is indicated for treatment of that. And we'll kind of go into some treatment modalities here in a minute. All right. Oh, more pictures snuck in. How did that happen? Who made this presentation? All right. So this is little Zuzu here with our dog Macy, who you can tell is really excited that she's getting crawled on. And then this is kind of her, like, it looks aggressive, but it's actually really an excited face. And she kind of almost snorts and stuff. It's yeah. It's one of those things, when before you become a parent, you go, people show you their kids' pictures, you go, oh yeah, those are really cute. And then you become a parent, you go, yeah, I see why they did that, because it's really fun to show people your kids' pictures. Anyways, I said I wouldn't be that person, and now I'm giving a presentation showing the whole world. So alrighty. So hepatitis C during pregnancy. All pregnant women should be screened with serology testing. So serology antibody, right? Antibody testing for each pregnancy. If this is positive, PCR testing, so nucleic acid amplification testing for RNA should be done to determine if this is a current infection or a previous infection. Normally, it's estimated that about maybe 1 to 2% of pregnant women will be positive for hepatitis C. But previous to this, previous to 2020, I should say, it was not routine to test in every pregnancy. Okay, so it used to be done as a risk-based assessment. So if there's a known history of injection drug abuse, if there's a known history of previous hepatitis C infection, of course, or various risk factors that the OB would be able to determine, they would perform hepatitis C testing. Now in 2020, the CDC did recommend that all women be tested at each individual pregnancy for hepatitis C. All right, from a breastfeeding standpoint, both the AAP as well as the American College of Obstetrics and Gynecology do support breastfeeding. There's never been a known case of transmission via breastfeeding. The only kind of caveat to that is if there is a cracked or a bleeding nipple, that temporarily be paused, and then once that is resolved, they can resume with breastfeeding. All right, so what is the risk of transmission in the neonates? So kind of focusing our thought from a general hepatitis C to more of a perinatal transmission, as well as kind of the NICU and the newborn nursery correlation here. Normally that risk of transmission is about 4 to 8% is what most resources said. Some saying more like 2, some saying more like 12, but 4 to 8 was the best figure I could find as a good happy medium. This can be at any point during either pregnancy or during childbirth. Okay. Unfortunately, there is no prophylaxis or treatment that is available if there's a known case. As we mentioned before, acute as well as chronic infection is generally going to be asymptomatic. So if you have an unknown prenatal history on a mom, meaning that we don't have hepatitis C testing, it's not going to generally be very evident either in the NICU or the newborn nursery that, oh, this baby likely has hepatitis C. This is going to be something that is not going to present generally with any specific signs or symptoms. Okay, continuing on with the risk, there are some higher risk situations where you're going to see an increased risk of transmission perinatally. So the number one risk factor for perinatal transmission by far is the viral load during pregnancy or birth. Okay, so when you look at an EPIC or whatever EMR system it is, you're going to see the serology test, yes, positive for antibodies. Okay, then you're going to see the OB perform the PCR testing as well, and you'll be able to see what the viral load will be. Oftentimes, they will actually follow that viral load throughout pregnancy too, particularly if it's a particularly high viral load. But by far, viral load is going to be the most, the highest risk factor for perinatal transmission. There is also a higher risk of co-infection with HIV as well, as we kind of also mentioned. That also bumps up your increase for any potential complications of the liver. So there are some factors here that do increase perinatal transmission. Most of those are going to be invasive procedures or modalities, internal fetal monitoring, vaginal lacerations, prolonged rupture of membranes. Those things are also going to increase your potential risk for transmission. Okay. One important thing to remember is that mode of delivery, vaginal versus C-section, does not have any increased risk. And so there are no indication or contraindication for one mode of delivery or not. It's whatever's best for mom and baby based on the OB's discretion. All right, so how do we test in the neonate and the infant? And this is kind of where some of the caveats will come. So as I mentioned before, the recommendation is serology testing at 18 months of life, but there are many caveats to that. All right, so I'm just going to read this off just because I worded it carefully. So all children born to hepatitis C infected women should be tested for hepatitis C infection. Testing is recommended using antibody-based testing, antibody serology, right, at or after 18 months of age. Okay. So this is both from the Red Book, American Academy of Pediatrics, Infectious Disease Society of America, as well as the American Academy Society for Liver Disease. Alrighty, so there are, as I kind of mentioned before, oftentimes RNA testing will be done in this 2 to 6 months, most often 2 months, of age, and really that testing is more of a risk-based assessment as well as a parental desire to know earlier than 18 months of life, because that's a long time, right? I mean, thinking about waiting 18 months to know if your baby has hepatitis C would be a long time frame. So One thing. So why the wait? So passively acquired maternal antibodies, meaning that antibodies from mom will oftentimes persist for quite some time, even up to 18 months. So for testing antibodies at 2 months of age, 4 months of age, well, our picture is going to be confounded with saying, well, is this mom's antibodies, is this baby's antibodies that are there? So that's why the serology generally waits. All right, continuing on. So why do we generally wait to 18 months? Why don't we just do it all at 2 months? Well, generally infants have a pretty low risk of perinatal transmission, as we mentioned there, 4 to 8-ish%. A lot of that being based on viral load as well. Generally, if infected, as I mentioned, acute and chronic infections tend to be asymptomatic. So they're not really going to present very early. And then probably the biggest thing is that there's no antiviral therapies before age 3. So if you got your information at 4 months of age, well, that from a mental standpoint might be a benefit from a parental standpoint. So I totally get that. But from a treatment standpoint, as of now, there is no treatment for anybody less than 3 years old. So if we got information at 4 months old versus 18 months old, unfortunately, that doesn't really change our management from a treatment standpoint. Okay, there are some exceptions, as I mentioned here. So the 2 exceptions are concern for follow-up. Okay, this is probably the biggest one. If you think about for our daughter Zuri is 14 months old, and thinking about the different doctor's appointments we've had for well child checks, sick visits, whatever it may be. Remembering something to 18 months of age, that's a long time to remember something. And so particularly if you don't live in town, particularly if, from a neonatology standpoint or from a newborn nursery standpoint, maybe we don't know their primary care doc as well. And just a situation that maybe would say, I'm wondering if this is going to be lost to follow up. It's really reasonable to do nucleic acid amplification testing at 2 to 6 months. The other option would be families that just desire to know. So they're saying, hey, I'm just curious. And I can't imagine, I could only imagine I would probably want to know too. So that testing this for RNA can be done at about the 2-month range. Definitive testing is still going to be serology at 18 months though, despite whatever your 2 or 4 or 6 month RNA testing shows. Okay. So what are our recommendations here at Sanford? And this will kind of go into a little bit of some of the data poll that we did, but our recommendations here as of now are recommended to do outpatient referral to Peds ID, okay? There are some exceptions to that. Generally, inpatient consult's not needed. When we went back through the data, sometimes they were consulted inpatient, which is obviously completely reasonable. But speaking with Dr. Lopez here, he generally says that's probably not necessary at the moment. Just refer to us and we'll follow up with them at 2 months of age. In some situations too, it's also reasonable for the PCP to perform testing as well. So if there's a PCP that you know and trust and you have good communication with and you feel confident that this patient will follow up with them and have close follow-up, PCPs also are able to do that testing at 18 months of life and can also do PCR testing at 2 months of life too, if they deem that to be something that the parents would like, or if they, based on their risk assessment of follow-up, something that they can also do as well. All right, so this is kind of goes into a little bit of the data that we pulled from our both NICU as well as newborn nursery here from about 2015 to 2021. So we pulled data from 2015 to 2021, looking at mothers who tested positive for hepatitis C at any point, either during that current pregnancy or have a history of hepatitis C. Okay. There are 57 mothers during that time frame which were hepatitis C positive. In our analysis was shown right here, just from a number standpoint. So we do see a good jump here in 2021 as well as 2018. We did see that recommendation change in 2020. So it's very reasonable that we saw that jump here, and anticipate we will continue to see a further increase in hepatitis C positive. So as I mentioned before, oftentimes, not always, but oftentimes this is going to be potentially an incidental finding because generally moms are going to be asymptomatic, certainly for the first couple years. Okay, this is kind of a more detailed look at some of the numbers that we have here. So as I mentioned here, from a total standpoint on the right here, we had 57 mothers who were positive for hepatitis C. 12 of those babies were seen by ID previous to discharge, so inpatient consult. 10 of them left with a follow-up with ID, left with an appointment. 14 of them did undergo PCR testing, at 2, 4, 6 months of life. 12 of them underwent serology testing, and then 17 either went one or the other or both, of course. So looking at that 17 are divided by 57, that's about 30% of baby were tested either or. Okay. So 25% with PCR, 21 with serology, 30 in general. Okay. This is just a graphical representation of the exact same thing that's in the table above. All right, so just a little bit more of a detailed look here. So in the left side, we have infants in whom further testing was indicated who had PCR prior to 12 months of age. So oftentimes it's going to be concerns about follow-up or parents who desire to know. So looking at the numbers here, 2021, we had about 50%. You look at 2018, 100%, whereas in 2019, only 20%. Okay. And then on the right side, we have infant in whom further testing was indicated who had serology testing after, it should read 18 months of life. Okay. 2021, say, well, gee, there's 0. Well, I haven't met the time frame to be at 18 months here. So that's kind of the explanation for that. But we have some nice numbers here kind of looking at the differences. There are definitely some limitations to this data pool, just for clarification's sake. 57 is a relatively small sample size. We only use the sample from here at Sanford, either at the NICU or the Newmar Nursery. We did not extend it to the enterprise-wide, so Bemidji, Bismarck, those types of areas. So we would have had much greater numbers, of course, if we were extending to Sanford in general. Okay. Difficulty with follow-up or just follow-up in a different health system is a very likely cause for a limitation here where we don't have numbers. So all these kids, for all we know, went somewhere else and has been seen by ID or PCP has done testing, and we just don't have details on that. And then finally, the babies born in 2021 a lot of them have not aged up to the 18-month range, so we're not going to have data for their serology testing if they do end up undergoing it. Okay, so from a treatment standpoint, oh, look at that, I've seen a trend here. So I've never seen a more fussy baby in a beautifully warm Boca Raton pool in my life than this one to the right. I think she's pretty sleepy, but it's just that picture's so funny. She looks like she's just over it completely. Alrighty, so what is our treatment and what's our management in general? So PEDS ID referral or consult based on what setting you're in, and then a plus or minus PEDS GI referral. Probably that GI referral not immediately, but certainly for definitive management and also for evaluation for any liver involvement down the line. So any kid 3 years or older should be treated. Any kid or adult, I should say, of course, but any individual 3 years or older should be treated. These treatment modalities are changing very quickly. There are a set of recommendations now, but from what I can tell, these recommendations change with some with a pretty good frequency. That's just obviously based on new data and better treatment. Okay. So I bring this up just to kind of reiterate the point that a lot of times, or that the treatment modalities are only indicated in greater than 3 years old, or greater than or equal to 3 years old, excuse me, without cirrhosis or with CTP classification A. So if we look at here, so the treatments that I'm about to speak about are not indicated for B or for C because their level of liver damage and their continuum of that cirrhosis continuum is going to be too great for this based on the studies that we have right now. Okay, so what is our antiviral therapy? I practiced these words a few, and I'm probably still not going to do a very good job at that. But for kids that are greater than 12 years old or greater than 45 kgs, you have this combination therapy with glecaprevir and pibrenstevir. Practice didn't really do a great job, but is going to be treatment for those kids greater than 12. For your kids that are greater than 3, you have another combination treatment for that kind of 3 to 12 year range of the ledipsevir and sofosbuvir for our other kids that are greater than 3. Okay. This is per the American American Association for the Study of Liver Disease, as well as the Infectious Disease Society of America. All right, continuing on with treatment, the mechanism of action of these is not for the purpose of this talk, at least not that important. The important thing to know is that what they do is basically inhibition of RNA replication. So you're inhibiting that further replication of RNA for these viruses. Continuing on, again, I know I've said this a couple times, but remember, it's only going to be for our Class A right here. Class B and Class C will not qualify for these medications and require much more thorough workup, as well as potential unique targeted therapies. So what do we do when we have a positive hepatitis C in a 18-month-old versus a 10-year-old versus a 40-year-old? Not that we're going to be taking care of them, but what do we do, and what are general monitoring for these individuals? So yearly, they're going to get liver biochemistries, okay, checking for any potential progression or even presence of any liver damage, okay. There is going to need to be monitoring for hepatocellular carcinoma, and so this is where particularly GI becomes involved. So endoscopic evaluation, looking for any varices and any potential scans that can be done for hepatocellular carcinoma involvement. Okay, of course, going to make sure that their hepatitis B as well as hepatitis A vaccinations are up to date. Not contraindicated, but want to be very careful about any hepatotoxic drugs that need to be used very judiciously in these types of patients, because any further insult to the liver can obviously progress any potential liver damage that might already be present or might incite any liver damage. As I mentioned before, complete abstinence from alcohol is recommended. Not thankfully as big of a deal in our populations, but certainly still very important to mention. Moderation is not recommended, but really abstinence. Again, easier said than done. Real life is different than the textbooks, but this is something that has really been harped on quite extensively throughout a lot of different societies and recommendations. Okay, so that's kind of the basics of what I had, and want to leave some time for any discussion you guys might have, comments, questions, concerns. Yes, Dr.
Sam, that was really informative. I was curious if you had a sense about whether the incidence that's increasing is related to disease and identification. Since the advent of new therapies, clearly many more people are being tested. And if that was why we saw that huge blip and it's leveling off now, as we've caught all those ones, they've gotten treatment and it's going down. I only know this because I sit on the Medicaid P&T committee, and we actually approved it in 2020. So then did you see that big blip, and then now we're seeing it go back down because we've treated them, but they're, or is it really an increase in the incidence of drug use, which is also through the pandemic?
Yeah, and I looked into that because I was wondering the same thing, since I was kind of trying to think. I mean, drug abuse is always, or not always, but has been there so that's not a new thing, right? So I didn't find any awesome data on it if it's really thought to be more due to increased testing versus actually an increase in IV drug abuse, because I was curious about the same thing. My reading between the lines kind of intuition from what I can get there, I think it's probably a combination, being that IV drug abuse can be a bit cyclical from what I can see. I tried to look up numbers and find some type of correlation. I did not find a great correlation, unfortunately. And I didn't find any studies that specifically looked at that. Reading between the lines, I do think it's probably a bit of both. But from a evidence-based standpoint, I don't have a great answer for that, because I was curious.
Do you think the incidence of children is the same or going up or down based on our treatment of adults? Or are we doing a better job of preventing it in children? That's my question.
Right. I didn't see it because I was wondering the same thing, and I didn't see any data, and so all my thoughts on that would just be speculation, reading between the lines. So I don't have an awesome answer for that, but I think it's a great question. I wondered the same. Hey.
Question. So the treatment's indicated all bringing up, but presumably there must be children that get hepatitis C, potentially clear that infection, and are never tested, potentially. So it would be kind of hard to say, like, are we doing a better job of getting to these kids without us ever knowing it? You know what I mean? Because there's that bias. It's like I'm biased where you're doing more tests.
Yeah, I mean, I think kind of to your point, with more testing comes more positive cases, which also comes more potential treatment, but also comes more data on how many of these infections are just resolving on their own. So I don't know how to rationale that. I think that's probably just that we're going to see that in the next couple of years, because really this testing only really was going officially totally recommended in 2020. So it's really early to tell that, given that those kids are just becoming 2 now as we speak. So I think that's a great point. And I don't know if probably take at least 5-10 years to really have some good data on that. So that's a good point.
Recommendations that were given surrounded moms and but what if mom isn't tested? Are there any recommendations for moms that for management of kids who maybe had a home birth or something like that to screen for?
Yeah, that's a really good question. I'm not sure about that. What used to happen before this 2020 recommendation was a risk-based assessment. So if there's a known history in mom, they could elect to do testing in the baby at the 18 months of age based on risk assessment. I've not seen any data on or specific recommendation of what that would be now that almost all moms are screened, because I don't know if that has changed now with that we're routinely testing everybody. So now this is kind of a new category for home birth or no prenatal care type of births and stuff like that. But it previously was done a risk-based assessment. Right, yes.
Questions. So the guidelines came out in 2020. Do you have a sense for how many institutions have adopted those guidelines yet?
Yeah.
And second, from a cost standpoint, do you happen to know the cost of testing a mom versus the cost of treating kids?
So yeah, great. 2 great questions. First question is, from what I can see, it seems like this has been picked up quite quickly by most institutions. I know that we do it here routinely with everybody. And from what I could see, based on different studies, as well as based on recommendation from ACOG, a lot of institutions are actually doing this previous to the official recommendation. So maybe that's a bit of bias in there that they didn't pick it up as quickly, but they were already just, doing it. But it does seem like this is a quite well adhered to recommendation. Cost wise, it's a great question. I should know that. I do not have an answer for that even remotely. Yes, I'm not sure at all. Yeah.
And they're adopted.
Totally. Absolutely. Yeah. That's a great question. Yeah. Dr. Hogan?
For the presentation. Actually, I'm just kind of, as Michelle, I'm just kind of surprised because I think one of the greatest breakthroughs that we had in medicine in the last 5 years was hepatitis C treatment. And as far as I know, with the adequate treatment, more than 95% of the patients are cured. So now recommendations are talking about Hep C eradication, and they have plans. I know United Kingdom has a plan for 20. So I was surprised to see that actually the incidence went up. It's sad to see. And the second thing is what if now the mom was diagnosed during pregnancy and she was adequately treated? Is that a thing? Do you still need to do the testing for the baby, or those medications, are they approved for pregnancy?
So not approved during pregnancy. So if a mom was previously diagnosed, has completely shown no viral load, complete resolution or complete resolution of infection with no viral load, the recommendation is a risk-based assessment for the testing in the neonates. Those treatments are not recommended for pregnancy. So if you hypothetically were to see a mom who, unbeknownst to her, had a positive testing for serology, but with no viral load, the testing in the neonate is then risk-based from thereafter. Yeah. Thanks.
I have a question. I have to
Yes, please.
So, the risk of hepatitis B blood transfusions, you said it's 2 per million units, which is a really interesting statistic.
because it's not per person getting blood, it's per unit of blood or platelets. And that's not nothing. It's low, but it's not nothing. And if you think about how many units we give our patients here in this hospital system, we've given multiple people hepatitis C exposure. And I just want everybody to keep that in mind when they're ordering blood products, that these risks are real. And not only do we need to say them out loud to families, we need to consider that in somebody that may or may not need blood. I think we get a little carefree and say, it's safe now.
Sure.
And it's safer, but it's not safe. And the same is true for HIV. Blood banks, big blood banks, like in Houston, for example, they're giving somebody hepatitis C exposure and HIV exposure every single year. To keep it in mind.
Thank you. That's really good perspective for those online who potentially didn't hear the Dr. Murphy with HEMONC, who is much more experienced in giving blood products than we do and does that very often, saying that, the data was per unit transfused, not per patient, meaning that most people will never get a unit of any blood product in their life, whereas a lot of particularly HEMONC kids will get many blood products, and so their risk is going to be much higher from a unit transfused standpoint. So yeah, thank you, Dr. Murphy. Questions or comments? Thanks so much for coming, everybody. Appreciate it.